And our next presenter is Professor Zeynep Gurtin. She's currently affiliated with the Sociology Department at the University of Cambridge. She teaches for various departments and faculties within the university. Her topics include bioethics and assisted reproduction for the Department of Social and Developmental Psychology, patient perspectives on assisted reproduction for the Department of Physiology, and gender, globalization, and reproduction for the Center of Gender Studies. She's also the founder and co-convener of the Cambridge Interdisciplinary Reproduction Forum, a research group based at the Center for Research in Arts, Social Sciences, and Humanities, which promotes interdisciplinary exchange between scholars working on reproduction. Her talk's title today is Access to Assisted Reproductive Technologies in Turkey, Pros and Cons for Women's Health. Please join me in welcoming Professor Zeynep.
Do you mind if I just pop this down, because I'm not using a PowerPoint? Thank you. So first of all, I'd really very much like to thank SEVDA for organising this, and to Dr. Thomas Maguire as well. It's wonderful to be here at this conference, and it's great to have the opportunity to converse again with colleagues that I very much respect and admire, like Marcia and Daphne, and to meet new colleagues, which I've been really looking forward to. So thank you so much for making it possible. Also, I think the topic that we've come together to discuss, women's and children's health in the Middle East, though often marginalised, is an extremely important one, not just for public health and development assessments, but equally for social and gender analysis. Indeed, I think reproductive health care and healthcare provision can be assessed as a key indicator of gender equality and attitudes towards and opinions about women's role in society. I had originally, when I was asked to give my paper title, planned to give a very sort of narrow talk specifically about assisted reproduction provision in Turkey, but in writing this paper in the light of various things that have been happening, I sort of felt compelled to try and situate that in what I see as the broader context of what's happening with regards to women's health and women's social role. So I hope you'll forgive me for that, and I hope that my sort of reasons for doing so will become clear by the end of the paper. So just to talk a little bit, start broadly. Although the Middle East has been a focus of attention for the West in various ways over the past decade, this attention has been severely biased and hardly positive. In the aftermath of 9/11, with the onset of the war on terror and the perceived growth of Islamic extremism, the gap between the West and the Middle East has widened, with the latter becoming more and more alienated, more and more associated with actual and symbolic threats to Western values, lives, and freedoms. Then, over the last 2 years, the Arab Spring has given the rest of the world another reason to turn its attention and focus to the Middle East, as we've watched in disbelief the uprisings in Tahrir Square and their reverberations throughout the region. Yet the lived complexities of these important social changes and political mobilizations, as well as the local moral worlds of men and women negotiating their 21st century identities in Egypt or in Syria or in Turkey, have been lost in much of the one-dimensional international coverage of these transitions. As neo-Orientalist stereotypes have re-emerged, Middle Eastern men have been caricatured as patriarchal oppressives, as religious extremists, and even as terrorists. So Marcia's book, The New Arab Man, which came out earlier this year, is a rare, detailed, and humane portrayal, a sensitive portrayal of Middle Eastern men that stands out as an antidote to these caricatures, providing instead a compelling and ethnographic detail on the real lives of emerging masculinities that are changing the landscape of gender identity and family relationships in this region, viewed through the lens of reproductive health and assisted reproduction. But what of Middle Eastern women? Indeed, if the men have been caricatured by an international media that feeds on fears, then women have often been barely visible. I attended a wonderful talk last week in Cambridge by Professor Akbar Ahmed, one of the foremost scholars of Islam, who's currently a visiting professor at the Cambridge Centre for Gender Studies, where I do some work. And he was adamant in his warning that Middle Eastern women are the group paying the highest price for a post-9/11 New World Order. Pigeonholed either as powerless, downtrodden victims of Islamic oppression in need of Western rescue, or vilified as cunning suicide bombers posing heretic threats, the voices of ordinary Middle Eastern women have been silenced. And it's high time to start listening to those voices. This is why I find it so important to come together in a conference like this, engaging in conversations across disciplines, across different countries and across specific research areas to draw attention to and discuss openly, critically and with nuance some of the most important challenges and opportunities facing these real women today. Middle Eastern women, as women everywhere, are not isolated individuals. They're daughters, their sisters, their wives, daughters-in-law and mothers. Their life stories, expectations and ambitions are not weaved as solitary tales, but as stories populated with important others, including perhaps most crucially the children that they wish to bear and raise with health and vigour. Whether explicitly or implicitly, reproductive health and healthcare plays a major part in these life stories and expectations, and it can make the difference between a life fulfilled and a life blighted. As our discussions throughout the day will no doubt reveal with fascinating examples, women's reproductive health spans an enormous spectrum, from sanitation, particularly for menstruation, for example, to access to reliable contraception, to prevention and treatment of sexually transmitted diseases, to the availability of legal and safe terminations abortions, pregnancy and antenatal care, qualified assistance during labour and delivery, postpartum and neonatal care, and even assistance with breastfeeding and infant nutrition. The presence or absence of such healthcare has a direct and crucial effect on the lives of women. That this is so is widely recognised and accepted, not only in academic discussions, but also in the priority setting of international women's organisations and international NGOs. For example, the fifth Millennium Development Goal has been to improve maternal health, with the goal to reduce maternal mortality by 3/4, to increase the proportion of births attended by skilled professionals, and to achieve by 2015 universal access to reproductive health. So this involves dealing with the unmet need in family planning, increasing contraceptive prevalence and antenatal care coverage, and lowering adolescent birth rates. Of course, that globally we are a very, very long way from meeting these goals is no secret. Nevertheless, even if it's not always evident in the policies of individual governments or even globally, governments who strive to distribute and allocate resources according to various principles of utility, fairness, and maximising benefits, while also negotiating what might be political and sometimes religious allegiances, that women's reproductive health is central to human rights and development is not a new argument that needs to be made here. These same ideas, Marsha has been, discussing those a little bit, is not true for how we look at infertility and fertility treatment. So often regarded as high-tech, therefore too expensive and low priority, assisted reproductive technologies have often been seen as a luxury rather than as a need for medical care. Particularly when we begin to look on a global scale, the dominant attitude is that there is not a particular demand for ARTs outside of Northern Europe and North America. And those regions are often readily associated with things like high population and low resources. Yet, as Marsha's talk made clear, and as those of us who work on ARTs in non-Western settings know all too well, the assumption of there not being a demand for ARTs in non-Western settings is wildly inaccurate. Firstly, it's a demographic paradox that some of the highest rates of infertility occur amidst those areas of the world that also have highest birth rates. So this is the infertility belt of sub-Saharan Africa, for example, that Marsha mentioned. Secondly, children are desired in poor resource and underdeveloped or developing parts of the world as a matter not just of personal fulfillment, so to which they are seen as absolutely essential, but also as a matter of social security in the absence of alternative infrastructures. As a result, the psychological, social, and practical burdens faced by men and women, especially women who are involuntarily childless in pronatalist, high fertility, poor resource developing contexts, is in fact much heavier and more severe than their counterparts in developed Western nations. Consequently, contrary to assumptions, where available, demand for ARTs has been really high among such populations. So just to refer to your really important question, while resource allocation and resource priorities do make it difficult to make these technologies available, I think from a humane perspective it's very difficult to make an argument that we should just focus on prevention and ignore the social suffering of people who are actually currently finding themselves infertile, which is what these technologies are trying to deal with. So the Middle East, in fact, has been a prime site, as Marsha has demonstrated, where fertility treatments have been enthusiastically embraced and where an enormous ART market has just flourished, particularly over the past decade. Since the world's first test tube baby, Louise Brown, in 1978, assisted reproductive technologies have rapidly globalized, including to the many pronatalist, child-loving countries of the Middle East. Yet the globalization of these technologies has also been accompanied by myriad local permutations, sometimes huge permutations, such as, for example, the Middle East in general, banning third-party assisted reproduction, large differences, but sometimes also small nuanced differences between neighboring countries. And these processes, these local permutations and these processes of localization have altered the character and created particular contexts within which these technological possibilities are delivered to and received by men and women. So Turkey, where I have conducted most of my ethnographic research in childlessness, infertility and assisted reproductive technologies, is an interesting case study to consider for various reasons. And I'd just like to take a little bit of time giving you a background of Turkey and contextualizing its position within the Middle East before talking about what's happening with assisted reproduction within the context of what's happening to women's health and reproductive policies in Turkey today. So, as us Turks are very proud of pointing out, Turkey lies at the geographical intersection between Europe and Asia, with the Bosphorus Strait dividing the city of Istanbul between two continents. But it's not just its geographical position, but also its history and politics that have continuously presented Turkey with an identity crisis. So its regional affiliations and allegiances are prone to changing on a fairly regular basis. Still not quite accepted as part of Europe, although it did enter the EU accession process in 2004, Turkey has also seen itself, especially during the 20th century, as distinct from, and by this distinct they mean better, more modern, more Western, than its Middle Eastern neighbours. Indeed, founded as a republic in 1923 based on the principle of secularism, separating religion from politics and law, Turkey adopted a progressive Western model of parliamentary democracy, as well as a civic, legal and penal system, self-consciously and deliberately differentiating itself from its Muslim neighbours, where Sharia law, the law of Islam, was seen as the law of society. Thus, seeing itself as unique within the Muslim Middle East, Turkey is often also hailed by other Western discourses as the exemplary realization of Muslim modernity, where religion has its place in culture but not in politics. However, this clear demarcating line has been becoming increasingly blurred, particularly during the past decade, since Recep Tayyip Erdogan and his Justice and Development Party, or the AKP, were elected to power in 2003. The AKP entered their third term of government with a strong majority in 2011, and they've been variously called centre-right, populist, or a neo-Islamist government. Although they've continuously denied sort of these accusations that they're trying to sneak religion in through the back door of politics, they have been actively and very openly pursuing a traditional and conservative agenda, with very particular and specific implications for women's health and reproductive health policies. Thus, for example, while GDP has increased by more than half and per capita income by more than a third since the AKP came into power, we're talking about a time where the rest of the world is suffering an economic crisis, so there's been really important economic growth, gender equality has been receding. Indeed, whether one regards the current stable and popular, I must say, government as neo-Islamist or not, the current political atmosphere in Turkey is both indicative and constitutive of important social and religious changes. As an example, the AKP has transformed the Presidency of Religious Affairs, Diyanet, into a central agency within government. It used to be a very peripheral, sort of symbolic agency. It's now been transformed into a very central agency with an annual budget of $1.6 billion, which is larger than the combined budgets of Turkey's European Union, foreign, energy, and environment ministries put together. Also, according to an article by Daniel Steinwert in Der Spiegel, there's now one mosque for every 350 people in Turkey, as opposed to, say, one hospital for 60,000. The UNDP classifies Turkey as a middle-income country with a strong economic growth, but states, however, that despite the numerous advancements, particularly in the Constitution, the Criminal Code, the Civil Code, and the Labour Act since entering the EU accession process in 2004, the implementation and de facto realisation of these rights is still a challenge, which is also reflected in the basic development indicators for women that are far behind comparable middle-income countries and much further behind the EU member states. Indeed, According to the Global Gender Gap Report 2012, which was published just a few weeks ago, Turkey ranks a dismal 124th out of 135 countries surveyed for indicators of gender equality on economic, political, educational, and health-based criteria. And this ranking is lower than Turkey's rankings in previous years, although admittedly more countries are also being included in the survey. Looking at the report in detail, it's interesting that although Turkey fares well for health, for example, ranking 62nd, it does particularly badly for economic and labour force participation of women. So, for example, 91% of births in Turkey are attended by a skilled health professional, and 92% of mothers have at least one antenatal care appointment. These are both important indicators for women's health. However, political participation at both the local and national level remain heavily male-dominated. Indeed, the employment rate of women in Turkey is currently at 29%, the lowest among all 34 member countries of the Organization for Economic Cooperation and Development. These figures are particularly important because, taken together, they indicate some things about women's role in society and the opportunities that are available to them. So, coupling it with the fact, for example, that mean age for marriage for women is 23 and first birth is under 25, it becomes fairly clear that social norms mandate motherhood as the primary and central identity of Turkish women. Moreover, there are many indications that there's been a regression towards more traditionalist and conservative family values over this past decade. And we can look at the provision of attitudes towards reproductive healthcare as a particular arena in which these can be analysed in more detail. So in my primary area of research, assisted reproductive technologies, Turkey presents this interesting profile. Having been one of the countries with the fewest IVF clinics per capita in a global survey conducted by Myro and Schenker in 1997, over the next decade, the ART industry in Turkey literally exploded. So currently there are, as Marsha also showed, over 110 IVF clinics in Turkey, and this is one of the largest numbers in the world for a similar sized population. While many of these clinics are situated in the predominantly major urban areas of Ankara, Istanbul and Izmir, there are also clinics extending into the farthest corners of the country, for example to Trabzon on the Black Sea coast and to Diyarbakir in the southeast. These particular locations are important illustration not just of the geographical reach of these technologies, but also of social acceptance of assisted reproduction in what are considered to be among the country's most traditional and conservative communities. Indeed, a report published in 2007 by a pharmaceutical company based on drug consumption listed Turkey as the world's 7th biggest IVF market. The expansion of this industry over that 10-year period has been particularly attributable to the provision of funding by state and social security institutions, which was introduced by the AKP in 2005 and 2006. According to these provisions, eligible couples can receive 3 rounds of IUI, or Marsha referred to as artificial insemination of husband's sperm, and 2 or 3 rounds of IVF as part of their medical packages. And really this is still very rare. This kind of coverage is very rare throughout the world. In England, primary care trusts are recommending 2 cycles of funding, but again, because of resource restrictions, there are enormous what we call postcode lotteries and very, very long waiting lists. Whereas in Turkey, I think, this is a positive move that the disparity, at least the economic disparity, with regards to access to assisted reproductive technologies has been dealt with by this kind of provision of funding. As Marsha described more broadly for the Middle East, in Turkey too, though, strong parameters operate to delineate who has access to assisted reproduction and which treatments can be offered. ARTs are considered a medical treatment made available only for heterosexual married couples with a medical impediment to conception. So all forms of third-party assisted reproduction, including the use of donor eggs, donor sperm and surrogacy, are strictly prohibited, as are access to ARTs for non-married couples, for single women or for same-sex couples. So these parameters are clearly the same as the Al-Azhar fatwa, the Islamic parameters for the practice of assisted reproduction. And although they are not openly justified with regards to those parameters in Turkey, that is clearly the mentality and morality which informs them. Despite the provision of despite the ban on the provision of third-party ARTs, however, Turkish couples who were unable to conceive their much-wanted children in any other way were pursuing donor gametes by recourse to reproductive tourism. The most common form this was taking was by fairly well choreographed infrastructures that enabled couples to start their IVF cycles within Turkey and then to just travel to neighboring Cyprus for 3 or 4 days for the donor procedure. And this was happening when I was conducting my fieldwork in 2005, 2006. This was not really spoken about very openly, but many clinics had what they called their Cypriot branches, where they could facilitate this kind of donor gamete provision. This extraterritorial choreography operated as what bioethicist Guido Pennings has called a safety valve, which allowed the minority to express and pursue their wishes by exercising moral pluralism in motion. So even though the majority in the country who are Sunni Muslim believed that gamete donation was not appropriate and it was not something they wanted, this safety valve was very important, particularly in a country where there is a large spectrum of religious adherence and religiosity, to enable the minority to exercise their will by exercising moral pluralism in motion. Then in 2010, in a surprising and radical move, the Turkish government actually made it illegal and punishable by law for Turkish citizens to go to other jurisdictions to access donor gametes. Now, this is a very radical position, and it was the first instance in law. It was the first sort of foray into trying to regulate against reproductive tourism. Elsewhere, I've spoken and written in detail about both the practical impossibility and the ethical consequences of trying to enforce such a law, which, you know, I think are clear to many people. But for our purposes today, it's probably most important to point out that this incident, this radical and unusual law, was not the AKP's solitary foray into reproductive healthcare provision and the laws governing them in the last few years. So I'd like to situate that within that broader context. On the 8th of March 2008, during celebrations for International Women's Day in the provincial city of Uşak, Prime Minister Erdogan made a speech in which he urged what he called his dear sisters to have at least 3 and preferably 5 children. These statements immediately drew strong reactions from national women's groups and feminists as being inappropriate and backwardly patriarchal. Then in 2010, during meetings with representatives of women's organizations in Dolmabahce Palace, he told them openly, "I don't believe in equality between men and women." Earlier this year, Erdogan announced what he called a crackdown on abortions and caesarean section births, seeking new legislation on both instances. So having legalized abortion in 1983, Turkey has a relatively liberal abortion policy, with terminations available until the 10th week of pregnancy. And until Erdogan tackled this subject, in which he specifically likened abortion to murder, and more specifically to the murder of PKK Kurdish civilians who were mistaken for PKK agents in the border. And until then, abortion had not really been a matter of public debate or interest within Turkey, and not even among religious scholars. As Marsha said, you know, in Islam there has been a very different interaction with questions over abortion and when life begins than perhaps we are used to in a Christian context. Following his remarks, there was widespread public outrage, and women's movements, in a very broad spectrum, mobilized under the slogan, "My body, my decision." And following this, the agenda for a new abortion legislation was swiftly abandoned. The question of caesarean sections, and these two questions had arisen together, however, followed a completely different trajectory, as Turkey became, again, the first country to make elective caesarean section punishable by law. So, on the one hand, the rates for caesarean sections in Turkey, which stand at 40% of all births in public and at 67% of births in some private hospitals, they're clearly higher than the 15 to 18% that are given as optimal by the World Health Organization. And they suggest that there are clearly non-medical and perhaps convenience and profit-related motives behind the prominence of this form of surgery. But on the other hand, taking such a radical and legal stand against them raises the question, as some feminists in Turkey have posed it, of why Erdogan feels the need to behave as if he is the guardian of the vagina. So, in sum, we see a reproductive landscape, a contemporary reproductive health landscape in Turkey, that is shaped, on the one hand, by good access to assisted reproductive technologies, a very good access compared to global comparisons, but only for qualifying heterosexual married couples, coupled with a unique and practically unenforceable ban on reproductive tourism, which nevertheless sends a very important symbolic signal. Added to this, liberal abortion laws that are under threat and are being discussed and threatened for the first time in a long time, and the world's only legislation against elective caesarean section surgery. So assessed as one entire spectrum, and there are other examples one could obviously add to this, these seem as the product of common underlying principles and priorities, where disparate aspects of reproductive healthcare provision highlight specific attitudes towards maternal health and the appropriate roles for women, where motherhood is foregrounded, if not mandated, and other reproductive choices are undervalued, if not disabled. It isn't a matter of Erdogan wanting to transform Turkey into a theocracy, states Istanbul-based sociologist Binnaz Toprak. It's about what the Americans call social engineering, the modification of social structures. So to just make a few brief concluding comments. I think reproductive health is key to women's lives, and the state of reproductive health or healthcare priorities in any given context can be examined as a very important and telling indicator of the value given to women and attitudes towards what their role should be in that society. Assisted reproductive technologies and infertility care, as Marsha argued, and as I resolutely believe, must be situated within the broader spectrum of women's reproductive health, addressed as an aspect of development and, I think, as an integral part of human rights matters, not held apart as a lifestyle luxury for the discretion of rich Westerners. For these reasons, and most crucially, actually, in recognition of the personal, relational, and social suffering that's experienced by countless involuntarily childless women and men globally on a daily basis, I think it's very important to enable and promote wider global access to ARTs. I am, however, sceptical and wary of the ideas and ideals generated by a government that endorses and promotes ARTs providing wide access, while simultaneously seeking to restrict other aspects of women's reproductive rights and freedoms, since it's only within this broader spectrum of reproductive healthcare provision that we can assess the pros and cons of access to fertility treatments. While ARTs can doubtless further an agenda to improve women's health and lives by enabling women and men to conceive the children they so desperately desire, it's important to make sure that these technologies do not become the handmaidens of traditionalist or conservative or religiously inspired ideologies perpetuating a heteronormative mandate for motherhood which constrains rather than increases women's life course options. I believe that if our agenda is to promote women's welfare and well-being, then the entire spectrum of reproductive health, from contraception to abortion to ARTs, must be about enabling choice, about giving women control of their bodies and the power to decide their reproductive trajectories. And this, I think, is a true challenge facing women's health and welfare in the Middle East. Thank you.